Hello, this is Dr. Kim Jong-il. Today is the second lecture on skeletal pattern analysis. Skeletal pattern through ODI, APDI, and CF can be classified into 9 types. When first children are born, most of them show a class 2. As they grow up, some children become class 3, and some remain class 2 or become class 1. During the growth up, if the maxillary posterior teeth are overrupting, there are 2 types of skeletal patterns. One is the open bite where the mandible is located posteriorly, and the other is the class 3 where the mandible is located anteriorly. One of the causes of skeletal class 3 is the anterior movement of the mandible due to over-eruption of the maxillary posterior teeth. First, let's look at class 3 high angle. The anteroposterior relationship is class 3, and a long face will be observed vertically. In general, mandibular plane angle and ODI are small, and a PDI value is large. The combination factor is also small. For example, ODI 60, APDI 90, combination factor 150. Class 3 high angle is greater than 85 for APDI, and less than 155 for combination factor. This skeleton is in the form of a skeleton, with the mandible protruding forward as the maxillary posterior teeth over-eruption. Mandibular plane angle is small, and linguversion of the mandibular incisors is observed due to dental compensation. The posterior vertical dimension of the posterior part is insufficient. Long anterior facial height is observed in the anterior part, and as the mandibular plane angle is steep, POP also steep. The patient's skeleton tends to be slightly open bite with ODI 51.8, APDI 101.2, combination factor 153, or ODI 56.8, APDI 91.7, combination factor 150.7. Let's look at class 3 low angle. This is a skeletal pattern that results from the overruption of the maxillary posterior teeth and the forward rotation of the mandible. Unlike class 3 high angle, the mandibular plane angle may change after treatment. As it is class 3, ODI is small, APDI is large, and combination factor is large. For example, ODI 65, APDI 95, combination factor 160 or higher. Therefore, for class 3 low angle, APDI is over 85 and combination factor is over 160. When the maxillary posterior teeth becomes overruption, the mandibular plane angle is flattened, and the mandible is positioned forward. In these skeletons, the palatal plane angle has a positive value, and the mandibular incisors show labioversion. Compared to class 3 high angle, this skeleton has sufficient posterior vertical dimension. Mandibular plane angle is normal or flat, and shows normal POP. Both patients have large combination factors of 161 and 163. At this time, sometimes it may show class 3 deep bite. Then how to treat class 3 high angle? There is not enough volume to arrange the teeth. Therefore, you have to extract a tooth somewhere. The best is the extraction of the mandibular third molars. The next step is to adjust the occlusal plane. The maxillary posterior teeth should be intruded, and the mandible should be located posteriorly. However, if your facial profile is not good at this time, you may need surgery. How to treat Class 3 low angle. First of all, you must increase the vertical dimension. In the case of Class 3, when the vertical dimension is increased, the mandible rotates backwards, which is helpful for treatment. Dr. Chung and Kim's thesis, when comparing Class 3 non-extraction group and extraction group. There was no significant difference in ODI, but only a PDI. And in the case of Class 3 non-extraction, the combination factor was 158 or higher, and in the case of Class 3 extraction, it was less than 155. Let's evaluate this picture again. Under the assumption that the palatal plane is the same, it can be seen that the anterior cross-bite of the Class 3 low angle is more severe than the Class 3 high angle. However, treatment is rather easier. In other words, the patient's anterior cross-bite may appear severe, but treatment can be much easier if the diagnosis is correct. In addition, face mask treatment is effective for patients in the growth stage of Class 3 low angle. This is because the face is round, so it will be helpful to rotate the mandible slightly posteriorly. On the other hand, since skeletal Class 3 high angle already has a long face and lacks the posterior part, face mask treatment is not desirable. Let's look at the patient case. This is a patient who came to our hospital after extracting 4 first premolars from another hospital. This is a case of Class 3 low angle. ODI 70, APDI 94, combination factor 164. Probably, the interincisor angle was small, and the mandibular anterior teeth were labioversion at the first examination of the patient. However, after treatment, the patient's IMPA was 60 degrees and the IIA was 173 degrees. What about the patient profile? Chin looks more protruding. There seems to be a problem with the initial diagnosis. This patient should have been treated non-extracted. So how can Class 2 malocclusion be classified? Class 2 malocclusion needs to be distinguished first, whether the maxillary posterior teeth were extruded, or the maxillary posterior teeth became under eruption, resulting in Class 2 malocclusion. Class 2 high angle or Class 2 open bite can become as the mandible rotates posteriorly and backward as the upper molar over eruption. ODI and APDI are small and the combination factor is also small. In other words, it is expressed as 70, 75, 145. At this time, the occlusal plane is different. This will be taught again in occlusal plane analysis. If the maxillary posterior teeth are under eruption and become Class 2 malocclusion, the ODI, APDI, and combination factor are all small. There is also a difference in the occlusal plane. In these cases, the mandible is often unable to grow forward. In particular, it is because the mandible cannot move forward as the anterior teeth of the maxilla are extruded, and the posterior teeth of the maxilla are intruded. Let's look at the characteristics of the Class 2 high angle again. APDI is less than 78, CF is less than 150. The mandible is located posteriorly and the posterior vertical dimension is lacking. This means that there is posterior discrepancy, and the mandible rotates posteriorly. Mandibular plane angle is steep, POP is also steep, and the anterior lower facial height is long. These patients are skeletally class 2 high-angle patients. Next, in the skeletal class 2 low angle, the mandible is positioned forward as the posterior teeth of the maxilla become over eruption. Or it may mean that the point of the maxilla is located more forward. If the skeleton is expressed as ODI 80, APDI 75, and combination factor 155, it means that the maxilla is located anterior to the mandible. Therefore, the characteristics of the skeletal class 2 low angle are APDI 78 or less, combination factor 155 or more, meaning that the mandible is normal but the maxilla is located anteriorly. The posterior vertical dimension is sufficient, and the vertical development of the midface is slightly insufficient. However, the mandible is protruding forward than the class 2 high angle. Mandibular plane angle is normal or flat, and POP is also normal or flat. These patients are skeletally class 2 low angle patients. In this way, we measure ODI, APDI, and CF. Look at APDI first, then look at CF, and measure the skeleton. Then, how should class 2 high angle treatment be done? In class 2 high angle, you must extract tooth somewhere. Whether to extract the first premolar or the second premolar will be described in detail in the next part of the diagnosis. The next important thing is to reposition the mandible by adjusting the occlusal plane. How to treat class 2 low angle? The purpose of treatment is to position the mandible anteriorly by increasing the vertical height. Let's review it again. In the case of maxillary prognathism, POP is relatively normal and there are many class 2 low angles. Mandibular retrusion cases show steep POP and have many class 2 high angles. For class 1 high angle, APDI is class 1 and the combination factor is small. This is easier to treat than class 2 high angle. The mandible has a slightly retrognathic mandible, and the posterior part is lacking. Mandibular plane angle is steep and POP is also steep. The patient will be presented with a protruding lip, an anterior tooth crowding, or a large overjet. In the case of class 1 low angle, it means that the mandible is located forward and the maxilla is also located forward. The mandible is normal anteroposterior, the posterior vertical dimension is sufficient, and the mandibular plane and POP are normal. However, in many cases, these patients have good facial profile, but they may also show protruding lip or crowding. Therefore, it is important to observe the aesthetic first before making a diagnosis. In addition, when deciding whether to have an extraction or non-extraction, the dental factors must also be evaluated. You can classify the skeleton into 9 types through ODI, APDI, and CF. Draw the AB maxillomandibular triangle with the AB plane, the palatal plane, and the mandibular plane and observe ODI, APDI, and CF. Data such as whether the inclination of the palatal plane of the maxilla is positive or negative. What is the occlusal plane, whether the mandible is located posterior or anterior? What is the classification of the angle, and so on, are very important for diagnosis. Thank you for watching.